Good morning, everyone. Before we begin, I would like to start by expressing my deepest gratitude to Dr. Bhuvan Nagpal sir and POPMA for this incredible opportunity and for your unwavering trust and guidance. To be invited to speak at this forum, especially in this early phase of my career, is truly an honor. I feel both privileged and immensely inspired to be speaking among such distinguished speakers. Honestly speaking, today I'm feeling equal excitement and nervousness as this is the first guest lecture of my career. So I thank you all in advance for your warmth and support as we dive into this fascinating subject, that is the role of artificial intelligence in oral cancer from basic to breakthroughs. In this lecture, I'm trying to provide a framework taking us from the basic principle how AI works to the groundbreaking clinical applications. So, the objectives of my talk are first to understand the fundamental AI concepts which are relevant to healthcare, recognize how AI is used in oral cancer screening, diagnosis, and treatment, appreciate the key breakthroughs through the case studies, and lastly, to identify the ethical and regulatory considerations. So, as we all know, oral cancer is second most common cancer in India, and it's a major public health crisis. Also, the Globocan 2022 data reveals over 1,43,000 new cases and a mortality rate of around 8.7%. This high morbidity and mortality are largely a direct consequence of late stage diagnosis. So, this is the problem we are trying to solve. So, why is early detection challenging? Our current methods are fundamentally limited. We rely heavily on subjective visual and tactile examinations. Also, the adjunctive tools like toluidine blue, Wellscope, while having a low specificity, it can lead to false positives, can lead to patient anxieties and unnecessary biopsies also. Also, most important thing is that the access to specialists is very limited in remote and rural areas. So, like this thing in the image, we can see that this image captures the dilemma. Is it an obvious malignancy? Is it an early suspicion? Or is it a benign mimic like lichen plants? So the histopathology, our gold standard, also has some limitations. It is time consuming for already overburdened pathologists. It has high inter and intra-observer variability, and even experts can disagree on some diagnosis. And again, specialities have in rural areas are limited, creating critical delay in diagnosis. So this underscores the need to augment the human experts. So this is where AI comes in. So before going into the applications of AI in oral cancer, it is important to discuss what is AI and how it works in our field. So this is very famous diagram. I must think that everybody must have seen this diagram. So there are three important things when we are talking about artificial intelligence. So artificial intelligence is actually the entire field of creating intelligent machines, and it has two subsets, the machine learning and then deep learning. So machine learning learns from the data and to make the decision without being explicitly programmed for every role. And deep learning has artificial neural networks, which is created like a human brain, which will process the image and will give the output. So for understanding these three terms, I have given a simple day-to-day life example to learn these three terms. So, artificial intelligence, we must say it is the big goal. Uh, the ultimate goal. For example, to making this machine smart enough to perform a task which requires a human intelligence. For example, unlocking your phone with your face is itself an AI. To reach this goal, we have to go through from deep learning and machine learning. Machine learning is the method to achieve this goal. So instead of programmer writing million of codes to describe every nose shape, eye color, they show thousands of images. So these thousands of images will be from different angles, from different light, with or without glasses, in different expressions, everything. And it will tell the AI that it is the same person. These all are the same person. And then the machine will learn, okay, when I have seen these thousand images and these are all the same person, if I am seeing any one of the image from that thousand image, I will identify the person. And the third thing is deep learning, which is a powerful technique for complex learning. So it has complex structures called neural networks. In the next slide also, I will talk about these neural networks and the layers of deep learning. Okay. So the first layer will detect the simple edges, the outline of the face. It will see what is the outline of the face. Next, it will combine the edges to recognize shapes like eyes, the lips. The deepest layer will shape highly complex patterns, and combining all this, the phone will be allowed to learn incredible details like the fact that you still look like you with a new haircut or a sunglasses or a big smile. So next I want to talk about how this convolutional neural network works. So in the last slide, we have talked about three things: AI, machine learning, and deep learning. So whenever we are talking about taking the image, analyzing the image in the histopathology, in the clinical image, we are almost every time talking about deep learning. So I've started with a standard clinical photograph the oral cavity. For example, is it an erythroplakia of the tongue? The CNN will take the image, it will convert into grids, pixels grids. Because we all know that computer language is different from our language. It works on the pixels. Okay, so it will divide it into so many grids, so many pixels with color values, each with one color value. The CNN will take the image, it will go through the first layer of convolutional neural network, which is the basic feature layer. So the initial layer will act as an edge detector that we can see in this image. It will detect all the edges. Okay, it will identify where does the red, white or ulcerated lesion end and the normal pink mucosa begin. Okay, so commonly known as a lesion localization. Layer 2 has pattern and texture location. The next layer will combine this edges. It will try to recognize what is the pattern. Okay, we have identified this is the lesion, but now we will identify how does the lesion look like. What are the edges? What are the texture? What are the pattern? Is the texture homogeneous or non-homogeneous? Is the color white? Is it a red or is it a mixture of red or white? Okay. It will check the shape, the border. Is it well defined, poorly defined borders? Is it irregular? Is it defined? Is the shape round or is it irregular? Okay, then it will go to the third layer, the complex pattern. The deepest layer synthesize these patterns into highly complex features that correlate strongly with clinical diagnosis. It learns the specific visual pattern. Okay, we don't tell the CNN that the red is bad or irregular borders are bad, but we show thousands of images to the CNN. Okay, if I am putting this erythroplakia, I will tell the CNN, okay, it is erythroplakia. Also, I am telling along with it erythroplakia high risk lesion. It is higher risk lesion or highest risk lesion. Then I'm putting it into the CNN. Okay, it will identify it is a mixture. It is both red or white. It is irregular border. It is poorly defined, and it will come to a picture. Okay, it is all these things, all these features will combine it into a high risk lesion. Okay. The step 3, the last, is the classification layer, the triage decision. All these extracted features are synthesized by the final layer of the network and it will perform a weighted calculation according to it. So, for example, it has given the lesion has a 92% confidence that it is malignant. The CNN is 92% confident that this lesion is malignant. So for example, by passing all three layers, it come to conclusion that lesion has 95% match for non-homogeneous texture, 90% match to irregular border, 85% match we are saying okay it is a red and white mixed lesion. Okay, so combining all these things, the CNN will come to a conclusion the pattern associated with this is malignancy. It is 92% confidence for this. Okay. So we have talked about how the CNN will take up the picture, how it will process it, what are the layers for CNN. Okay, but a powerful engine is useless without the right fuel. For AI, the fuel is data. Not just any data, but it should be vast, it should be of high quality, it should be annotated. Very important, the annotated data. In the next slide, I will also talk about the data annotation. This means for every image, an expert must manually label it. And I'm taking a emphasis on expert. Drawing the boxes around the lesion. For example, here I'm showing the images that how clearly they have pointed that this is the lesion, this is the lesion. Okay, so it requires a massive human effort and we need a diverse data types. For example, clinical photos, the histopathology slides. For histopathology we recommend whole slide imagings, radiographs, the genomic data. But this introduces a very high challenges, the data privacy, the standardization, and the bias. A model trained on data from one population may fail onto another population. So important thing that I wanted to talk about here is the garbage in and garbage out. So it is important that we are giving a high quality data, very high quality annotated data to the CNN. Only then we will able to get a very good output and we will be able to create a very good AI for our purpose. So we have established that data is the fuel, but raw data is useless to anyone. Okay. So this data annotation is a process of labeling the raw data images with meaningful tags. So to create a ground truth for training AI models, but it has some challenges. It is time consuming. Even an expert can take around 10 to 30 minutes to annotate a single large histopathology image. It has subjectivity, it has inherent variability among experts. For example, drawing precise tumor borders. It is obviously cost will be high because the time is more, we need more expertise for this. Accuracy of AI is directly bound by the quality of human annotation. So for a clinical photograph, what I'm showing here is this is an application that we can all use to create a lesion localization that we can see here. There are many applications available. For example, there is application Appear that I have used to create this localization thing. We can use Appear on our histopathology slides also. We can use it on clinical images also. So here ultimately that we are showing that this is the lesion and this whole is a background. So that AI could learn that what is the normal mucosa and what is the lesion. This is an example that I wanted to share here for annotating the histopathology slide. This is the Vineta image viewer on which you can open a whole slide image. This is for a project that I'm doing currently, and here I wanted to show how we are doing the annotation. This app is very good as we can create a text annotation here in the box that you can see here. So what I wanted to do in this project is I wanted to teach the AI the depth of invasion, how we are calculating the depth of invasion, how can they search for the basement membrane, and how can it will look for the tumor islands. I have located the tumor islands here and the depth of invasion, and the important thing is it is giving the depth of invasion measurements in pixel, which is good for computer. It will learn the pixel only. And here, if I am giving this much annotation, if I click on third or fourth or fifth, I will come to know, okay, this is my fourth annotation, this is my fifth annotation. Okay, next important thing is data augmentation, which you must have come to this term when we are reading any article related to AI in oral cancer. So, why data augmentation is necessary? It is two important one. Most important thing, which is factual thing, that it will increase the size and diversity of a training data set from existing data. So what comes under data augmentation is, this was the your original image, we have rotated this image, we have created a mirror image of this image, and lastly we got the all of the image. So from one image we have created 8 images. Okay, so it has artificially increased the size of the data also. But most important thing is, it makes the AI model more resilient to variation, because in data augmentation not only rotation and mirroring comes, it also includes a different lightening, also different brightness, different contrast also. So it will make our AI model reducing the overfitting. That is the most important advantage for data augmentation. It will stop the AI from learning irrelevant shortcuts, like memorizing that every cancer in our data set has a specific blue tint. Okay, if I'm showing this blue tint, it is always oral cancer. So AI will learn these things also. This is overfitting. So instead it will force the AI to learn the fundamental invariant feature of the disease. So now we will go from the core applications from basic to advanced. So the benefit is clear. It will empower the general dentists and primary care providers. So AI as a clinical decision support system. Okay, here I'm talking, how can AI help us? Okay, this is the first thing that we can see here. It is a interface for a mobile application. Supposedly we have uploaded, maybe not we, but any general dentist and primary care provider in CHC, PHC who do not have any access to specialists, they can capture just the photo of the lesion. It will upload into the app interface, which has learned through the AI, and it will give, okay, it is suspicious, we recommend biopsy for this. So it will benefit the general dentist and primary care providers. It will flag the suspicious lesion and go for the referral. Second important thing is augmenting the pathologist microscope. So the most important thing that we are talking nowadays is, the benefit here isn't replacement, it's augmentation. We are not trying to replace the clinician, and AI will not replace the clinician, but it will augment the clinician or the pathologist. It will increase the throughput, it will reduce the subjectivity, it will free the pathologist valuable time for the most complex cases. So here in the image, what we are trying to see is the AI analyzing the entire digitized pathology slides, that the whole slide imaging that we can say here. It is a whole slide image which is unanalyzed. In the second, we can see it is analyzed image. In the green, the healthy tissue, red, it will mark the tumor region, blue here, it will mark the immune cell infiltration. Okay, so this will be very helpful, and it will not leave any minute details. So the task is, can be tumor identification. It can identify the tumor, simple. It can grade the tumor. It is well differentiated, it is moderate differentiated, it is poorly differentiated. It can count the mitotic figures for all our cells. It can measure the tumor invasion depth, like I was doing, the depth of invasion we can measure. So it will benefit so much. It will free our time. Third important thing is predicting the outcomes which are beyond the microscope. So AI can integrate the multimodal data. It will include the pathology images also. It will include the genomic data of the patient and simply the patient history, the clinical data, the name, age, demographic details, the chief complaint, the radiographic detail, everything it can include. It will give it to the artificial intelligence model, and we can get the risk score for this. What are the likelihood of the recurrence? What are the likelihood for metastasis? What could be the response to specific therapy, for example, immunotherapy? So it would be very helpful. Obviously, it is very much future, but it is possible. So this moves us towards truly personalized precision medicine. So let's ground this in reality with some published studies that I wanted to add in my presentation to give you all insight what are the things that we can do, what are the things that are already done in this research. So the first research I wanted to add here is the research by Song B et al. In 2022 for automated classification of dual modal imaging based oral cancer screening by deep learning. So this research is aimed to develop a low cost smartphone based system for use in low resource settings. So what they have done is they have created a fusion model. They have combined both the white light and the fluorescent oral images to improve the classification. They have given the simple white light images also, and for the same region, same location, they have given the fluorescent oral image also to improve the classification of AI so that it can detect the lesion more conveniently. So they wanted to see if this fusion model is better than only the white light oral images. So they have come to a conclusion that there is increased accuracy of 86.9%, 85% sensitivity, and an 88.7% specificity, meaning it's good at avoiding the false positives also. So crucially, it is designed for community screening, not definitive diagnosis. So acting as a powerful triage tool. It is not a definite diagnosis, but we are screening. Okay, this thing, this region, we have to refer, or we should do the biopsy. We should refer it to the specialist. Another compelling study focused on classifying the photographic images of the lesion is done here. So this study is done in year 2021. They have taken 684 cropped lesion images from photographic sources and then annotated by the expert pathologists and categorized based on histopathological diagnosis. They have already know the histopathology diagnosis. Okay, this is the lesion. So they have marked this is the lesion. This is the ground truth in the green. This is the lesion the experts have marked. This is the lesion. And for the prediction by the AI, this is predicted. This is the lesion. And then also done by the instance segmentation in the previous slide, that how I have showed now, that they have created the full location. So actually this method is better than this because it will include more things. It will include the teeth also, here the surrounding mucosa will be included. So this method is more convenient and more output giving. So this model has distinguished between the benign OPMD and carcinoma lesions. The third important thing is moving to histopathology. This study has tested on AI models. This study was done in 2023. They have given many oral mucosal lesions, the normal oral mucosa also they have given to the AI OSCC normal. So they have tagged, okay, this is normal, this is OSCC, this is normal. But they do not annotated the data. They only gave the full images to the lesion. So they are giving the thousand of images to that. Why I have included this study, that I wanted to show there are so many models available for AI, and like this here they have taken VGG16, VGG19, ResNet 50. So how when we are reading the articles, we come to know, okay, this is something is VGG16. So VGG16, as we have talked the CNN, there are so many layers for CNN. We have talked about, okay, this there are 2 layers, there are 3 layers, but actually in the real world there are so many layers. So based upon that, and what type of layer, how many pooling layers are there, how many identifying layer are there, based upon that there are so many models of AI available. And on that we are checking our histopathology image and coming to a conclusion, okay, among these five three models, which model has the best efficacy to classify the OLCC histopathological images. So in this study they have come to know that okay, ResNet 50 is has shown high accuracy and a minimal training time also. So ResNet 50 is very good. So this is significant because it shows pre-existing powerful AI architectures that could be successfully adapted for oral cancer diagnosis. And we will come to know, okay, this model is good. In the next study, we can compare this model with another good model that we have identified from another study. So we will get a very good model which would be good to identify, to classify our histopathology images. This study represents a true glimpse into the future. That's why I have added this study. This was done in 2023, and the team developed a model that could predict the Ki-67 positivity, which is a marker of cell proliferation, directly from the HLD stain. So they have put this input image. This is the ground truth, which is the actual Ki-67 IHC stained slide, and this is the predicted image by the AI. On the histopathology slide only, they have detected, okay, here must be the Ki-67, and this is the real truth, the real Ki-67 ISC stain. So they have concluded that there is moderate correlation between the synthetic and real Ki-67 positivity. However, the relation was moderate, but it demonstrates the feasibility of virtual staining. So this could drastically reduce the laboratory workload, the cost, the turnaround time, and it represents a genuine breakthrough in the efficiency of AI. So, important slide. As we stand on the brink of integrating these powerful tools into our clinical practice, we must pause and address the critical ethical and regulatory framework that must guide us to adopt the AI into our clinical practice. The goal is not just to build an accurate AI, but to build a responsible and equitable AI. So the first thing is data privacy and security. We have a fundamental duty to protect this data, the patient data, ensuring the anonymization, the compliance with regulation. Second important thing is algorithmic bias. If we train a model primarily on a data on one demography, say urban population in one country, it will inevitably perform poorly on a patient from a different ethnic background or from a rural community. So we must demand a diverse and representative training sets to build AI that serves all, not just a subset. This leads to a third challenge, that is the black box problem, which is very common. Now we are talking about the black box problem. So if an AI says a lesion is cancerous with 95% confidence, but it cannot show us why. Why would you base a life altering decision on it? This lack of transparency to a major barrier to trust. So there is emerging field called explainable AI, which is very important. It will aim to solve this thing by creating the heat maps on the image that shows clinicians exactly which area of the image most influence the decision, turning a black box into a glass box. In the black box, we don't know why this decision was done, how the AI have done this decision. So for doing this, explainable AI have come into the play, and it will show this was the heat map. Okay, based on this location, based on this thing, I have concluded that this has 95% confidence for cancerous lesion. Furthermore, we establish clear liability and accountability. If an AI system misses a cancer, who is at fault? The surgeon who used it, the hospital that purchased it, or the developer who built it? So, our current legal frameworks are not equipped to handle this, and clarifying this is essential for adoption. Finally, all of this culminates in the path to regulatory approval. AI-based software for diagnosis is classified as software as a medical device, SAMD. It cannot be simply deployed. It must undergo rigorous clinical validation and an approval from agencies like US FDA, India CITES. So this process is designed to prove not just algorithmic accuracy but real world clinical utility and safety. So this leads to the most important point. AI will not replace the clinicians, but clinicians who use AI will absolutely replace those who do not. This is very important statement. AI will be our most tireless microscope, handling the quantification and the triage. The clinician will provide the empathy, the complex judgment, and the final decision making. So it's a partnership. Concluding my lecture, I just want to say that oral cancer diagnosis is plagued by subjectivity and late detection. AI, particularly deep learning, offers powerful tools for automation, for example, detection, grading, and discovering novel biomarkers. The future lies in human AI collaboration to enhance diagnostic accuracy and personalizing the patient care. Thank you for your attention and engagement. Thank you.